There are a couple of important things that came out of the DARE discussions with ARAMIS. First, the bar was already set kind of high. With enzalutamide and apalutamide already being available and in use in most clinicians' hands at this point, DARE had to demonstrate that it was just as active, and I think that bar was very clearly met. No one left that room thinking DARE was a day late and a dollar short in terms of activity. Some things that were emphasized were interesting, and some were probably underemphasized. The chemical structure, it was nice to actually have them up there for the aficionados in the audience, but even for the non-aficionados, one thing was very clear. It's a very different molecule, and that's important. The folks at Bayer have emphasized its lack of penetration in the central nervous system, and they believe that will strongly impact toxicity. The data seems to support that so far. The trials are still small, and so as more data comes in, as we get these larger and larger studies that report, including studies like Titan that are down the road, I think that'll be more interesting to see how the toxicity matters play out, especially in a sicker population. But another interesting and important fact was that because it's molecular nature, the drug-drug interactions that are to be monitored or considered in making a therapeutic decision, they're actually kind of important. Men with prostate cancer are older, they're already on different pharmacologic agents. Having to alter those things can be painful and disturbing sometimes, especially those with complicated medical conditions. And the fact that DARE has fewer drug-drug interactions is a big plus. But with 3 active compounds now, everyone is kind of looking to say which one, who's on first and who's on second, and is there a role for being second or third? The answer is possibly, and I think that's going to speak to the biological phenotypes, which is why I wanted to mention, the FANG presentation, the Rubin presentation, and the Beltran presentations, because they all speak to this. What we know about prostate cancer is that it has the ability to shift in this kind of lineage plasticity phenotype, or this lineage plasticity behavior that a lot of us in the laboratory are looking at. I think that will strongly influence the ability or the need to hit the androgen receptor with these different agents.